Okay.
Maybe just say these are all concerns and
Hi, ladies who are here today.
oh, we're in now, are we?
Well, I'm going to do my best. I don't have my technical expert. I am feeling vulnerable.
God, it's us. Don't feel.
I know. At the end of the day, it would just be what it would be.
Yeah.
Lindsay's on her way. I don't know if she's coming from the office, but we'll get started because I'm also just on a lunch hour. So, woo.
We'll get started.
Okay, ladies, I'm on my lunch hour, so we gotta get started here. More than welcome to chat after. I love the chatter. Lindsay's on her way. I don't know if she's up at the office, but so you'll have to excuse me. Hopefully everything goes well technically. This is not my forte.
You won't remember it after you've messed up anyways.
You know what? I haven't watched any one of the recordings that we've done because I hate seeing myself on video. I was like, I'm just gonna like be so upset with myself whenever I mess up. So today we're going to talk about physical health and exercise. So physical health is more than just exercise, but as you'll find out, it's really intertwined in basically everything we do. If you haven't done the quiz, please do. I know that Maggie does send out the link ahead of time. If you haven't, feel free to take a screenshot of it now. I think we do have quite a few people online. 16. There was we had to move the evening session back a week because the snap election took over the ALC. So we had to push it back a week. So it was a week before. So I know a lot of people could make it. Plus, that was the night of like one of the crazy snowstorms. So we have a lot more online than we normally would. And of course, this session here is going to be recorded and sent out. So we weren't able to record the ALC night. And just want to thank Ashley Moore, who came to that session ahead of time and did kind of a learn to lift session with people. She brought some of her barbells and kettlebell and some weights and stuff, and just taught us a few simple movements with weights, which was really great. Yeah, so thanks to Ashley for doing that. Oh, okay, now how do I move from slide to slide? Oh, look at me go. Ooh, I'm gonna get this eventually. So exercise and physical health during menopause and beyond. So hopefully by the end of today, we'll give you an overview of the physical changes during menopause and their health implications. We've talked a little bit about this, but it is like it's kind of intertwined in all of them because there's such a big impact. We want to discuss the power of physical activity. Some people don't like the term exercise. Sometimes you just call it moving your body. Exercise can give some of us hives, literally and figuratively. So I like to just say movement, however that looks. And the goal is to provide information to understand physical changes during the menopause transition, which is, perimenopause and also beyond. And hopefully provide you some practical tools to mitigate and in some instances reverse adverse effects that health at this age can bring. Oh, I forgot my tea. My mouth is dry. Okay.
Yeah, I've done my
Was that? Do you have a question? Maybe it was just an unmuted mic. So I put this up here. I found that book because Feminine Forever, so back in the 50s or whichever it was when they kind of first discovered hormones and they figured that they could extract estrogen from the urine of pregnant mares, which is where Premarin comes from, pregnant mare's urine. It was this book was written by Feminine Forever was written by a Dr. Robert Wilson. It was backed by Big Pharma, so that's always an issue. But the it was marketed as like being feminine forever to keep your boobs perky and to be young and desirable for the men in your life. Stay with life, right? Exactly. That's what I said. And I liked it. Sorry, you guys online are have to watch me squinting here, but a fully documented discussion. No, wait, what did it say? Yeah, a fully documented discussion of one of medicine's most revolutionary breakthroughs, the discovery that menopause is a hormone deficiency disease. It's not a disease, it's a natural part of life. Anyways, um, curable and totally preventable, and that every woman, no matter what her age, can safely live a fully sexed life for her entire life, right? Like, that is right. I like, if you want to live a fully sexed life, that is fantastic. Like, please do. But to have it marketed as that is just gross, right? Anyway, so I put that up there because that was our mother's menopause. That was what the 50s and 60s was all about, was staying youthful, and that's how it was marketed. Um, but it's more than our mother's menopause. It's more than hot flushes, more than mood swings, and definitely more than has to do with sex and pleasing the mighty penis. It's just absolutely ridiculous. So we need to focus more on the major health implications that come along with this phase of life. And as we have learned, which I think almost everybody the other night put their hand up to say that, like, heart disease is kind of one of those big ones up there now that they worry about more than it used to be. I used to ask that question. It used to be maybe cancer was the biggest scare, and they're all scary. Like, I think we might put them all in the same um, risk, like what things that we're afraid of as we get older. But the cardiometabolic disorders are the ones that have the biggest impact on women. Um, and research indicates the women at this phase of life are particularly vulnerable to cardiometabolic conditions, so meaning heart disease. So estrogen has a protective effect on the pump, which is the heart, and the pipes, our blood vessels, are busy, coupled with our busy schedules and stress, demands of trying to be Wonder Woman. We're trying to take it all on, and we do sometimes. We're not very good at delegating often. I'm terrible at delegating, some control issues. Fine, I'll do it myself. And trying to be Wonder Woman on the daily can make it challenging to maintain a healthy lifestyle. So you'll notice a theme throughout this chat. There's no magic pill, magic cure, magic patch, magic anything other than physical exercise and keeping yourself moving and looking at lifestyle changes. Other things can supplement and help and solve some problems, which we'll get into. But at the end of the day, we need to prioritize our lifestyle and our health in that sense. And also, family history plays a significant role. So at this phase of life, so men tend to have heart disease earlier, and they think that has something to do with the testosterone. And also they don't have a ton of estrogen and stuff. So we do know that estrogen has protective effects, which is why women post menopause, women and men get heart disease or have the same kind of or similar levels of heart disease in that population. But before menopause, men have heart disease a lot sooner than women. So that speaks a little bit to the protective effects of estrogen. Um, yeah, number one killer, cardiovascular disease, otherwise known as heart disease. In Canada, one woman dies every 16 minutes from cardiovascular disease. So that's a bit sad. And it is the number one cause of death of women worldwide, 1 in 3. Women are 5 times more likely to die from heart disease than men, for many different reasons. The research also indicates that women are more than twice as likely to die after a heart attack than men. One study found that women under 55 have an 84.3% higher mortality, so death rate, after heart attack compared to men. And I think the potential causes of that disparity were often dismissed. We experience visceral pain, so that the pain of our internal organs. So we're used to having period cramps, those kinds of things. So I think sometimes either we might minimize the pain that we have in, say, our heart, or other things like that, and also our doctors may. I was brought up in a patriarchal medical system. That's how we were taught things. We didn't focus on women, and so, oh, that's probably Lindsay there. I wonder if somebody's out there. Awesome. Thank you. Yeah, so historically our pain has been dismissed or ignored. It's called anxiety, or back in the, 50s or 60s, we were hysterical. And we were put in asylums because women of menopausal age were finally sick of everybody's shit, lost their shit on everybody, and they decided to put us in asylums. We're just like, no, we're just done. So I think we and indigestion, stress, and we minimize our pain, and our doctors also might minimize our pain. And if a man presented with the same symptoms, my question is always this: if a man presented with the same symptoms that a woman's complaining of, would he be Oh, are you sure you're not just anxious? Like, how many times does a physician say to a man, "Oh, it's just anxiety, my dear. Try to get a bit of, reduce your stress a bit." So or put on an antidepressant. Like I think women just kind of get lumped into anxiety, stress. When you
You're
look at
being dramatic.
they're being dramatic. And when we look at the movies, what do men die of in movies? Other than like car crashes and stuff, big heart attacks, that holding the arm, the chest pain, and the sweating. And women die of cancer. And these little frail little things that this is how we're portrayed in the movies as well. Um, we don't always have the same symptoms as men. It doesn't always present the same. And as a nurse, I saw this time and time again with women and be like, I don't know, I've just got this weird pain in the back of my arm, or I just can't get rid of this pain in the back of my neck. And you do an ECG and do all the tests, and they're having a heart attack. It's not that crushing, sweating, elephant sit. Sometimes it is sitting on our chest kind of thing. So it really takes a knowledgeable and curious healthcare provider to do all the tests and not just, no, it's just anxiety or whichever. So, um, yeah. What did I say? Gosh, I like some of the things I write.
Palpitations is another thing that I hear in my office
Mm.
really frequently.
Yeah.
And a lot of women are dismissed with palpitations, saying it must be your stress levels.
Yeah.
Right?
Yeah.
Without actually doing a proper workup.
Yeah.
When the guidelines would say anyone with palpitations needs a Holter
Yeah.
monitor.
Lindsay's here now.
Oh yeah, hi.
Yay. Yeah. So, and there's a persistent misconception that heart disease primarily affects men. So it affects men before, like I said, before menopause, but after, it's kind of the same. Um, the perfect storm, hormones, lifestyle, and bias, like we kind of talked about. The decrease or decline in estrogen. Estrogen has protective effects on our cholesterol. The way it's metabolized in the liver impacts our cholesterol and our LDLs and HDL. So it increases our LDL, which is the bad one, the low density lipoprotein, and decreases our HDL, the high, which is the one we want. And um, so you could have eat the same things you've always eaten your entire life because you're a creature of habit. You could do the same exercises that you've done for your entire life because again, you're a creature of habit. You've not gained any weight at all, and you go into your doctor, and all of a sudden you've got high cholesterol and you've got high blood pressure. You're like, what the heck? Like, I've nothing of my body has changed. There's no visual, but that's part of the reasoning. And also, estrogen impacts our collagen, which also impacts the elasticity of our blood vessel walls. So when they become more stiff, they can't move as well when we have blood clots and things like that flow through, and we get a little bit of plaque because we tend to get that. So it's kind of like one of those perfect storms. So those are the protective effects that estrogen has. And also the slowing of our metabolism, which we'll talk about in a bit. We can get more weight gain, and often the studies don't really show that menopause itself causes subcutaneous fat weight gain, but it often can shift. It'll shift to that midsection.
It's visceral fat. So it's fat around your liver. It's fat like in this midsection, which puts you at a significantly increased risk of heart disease and cardiovascular stuff.
It's metabolically active fat. So
Yeah.
it's diabetes, heart disease, non-alcoholic fatty liver disease. So we're seeing higher incidences of cirrhosis that's not related to alcoholism. But often it's still one of the things the doctor, are you sure you don't drink? It's like, yes, I don't drink. And I've never been a heavy drinker, but now we have like the liver is looking like it's scarred, like somebody has alcoholic cirrhosis, but it's from fat accumulation
deposits.
and visceral fat.
And you can see that in an ultrasound. It'll say like fatty liver or hepatosteatosis of the liver is what will come back, and that's that redistribution putting you at higher risk of heart
attack. And like we talked about, stress and multitasking, we often prioritize everybody else over ourselves. So this might be a time to be like, hey, you know what? It's a little bit of time for me. setting those boundaries. And as I said, and I will always say, the medical bias. We're hoping to change that. But women's heart disease is under-researched and undertreated. The medications that often were prescribed were tested on men, not, and some of the statins are a good example of that. Your cholesterol lowering medications, which we need, some of us do need, but again, there was no research done on women about those statins, and so how do they impact us? So I think there's more coming out.
I have type 1 diabetes, so I'm at increased risk anyway. And I was put on a statin in the last year by my specialist. And I asked him in our last meeting, I said, is there any difference in female like efficacy with these statins versus men? And he was like, blank stare.
The heart specialist, right?
Yeah, this is it. He was like, I have no idea. I don't know anything about that. You can do your own research.
Yeah.
Literally. I was like, okay, I will.
Okay. As long as he's open to you coming back.
He is very much,
Yeah. Yeah, exactly.
He wasn't dismissive, but he wasn't aware.
Well, at least he didn't try to
That's right.
say he did know.
Yeah, that's true.
I'd rather my doc say, hey, I don't know.
So if you go back, you can educate.
I can. I've been trying.
Yeah, there's not a lot out there on
It's
statins.
so true.
Mm-hmm. So speaking of statins, do you want to talk about this stuff?
Yeah.
I had you listed on all these, but
okay. Yeah. I don't even know these slides, but we're going to do it.
you know what? I had a little, some things in there to help me.
Yeah, you
said you couldn't come last time, I was like, oh no, I got to type in all the medical stuff.
I missed the evening session this month. I was catching babies. So yes, declining estrogen, just like Angie said, worsens lipid metabolism. So risk factors are diet, the nutrition. I tend to, whenever I'm even going to say the word diet, even if it's very appropriate, like here, I've started saying nutrition instead, because diet has that connotation that we've all grown up with, diet, weight loss, that thing. But high in saturated fats, the processed foods show increased risk of heart stuff. And of course, movement is so important, as most of you guys know already. And what helps? Moving your body. Changes in nutrition involving whole foods, less processed foods, less saturated fat choices and proteins. And we often in family practice, our recommendations are screening every 2 to 3 years is what I do in my practice.
Started at what
screening
age?
At 40. At 40 and above.
Unless you have risk factors.
Exactly.
Younger kind of thing. Okay.
So if your mom had a heart attack when she was 45, which would be atypical, would make me think that there may be a genetic predisposition and she would get screening, I would say, kind of like the mammograms 10 years before.
10 years before. Yeah. Start at 35. Yeah. But otherwise, for somebody who's healthy, generally healthy, with no increased risk factors,
it's 40.
About 40.
And then every 2 to 3 years, non-fasting. We used to have to fast to get our lipid profile, but now it's a non-fasting test. And they measure LDL and non-HDL, which is supposed to be something that's not affected by the fasting state that corresponds to the LDL. So non-fasting, easier test and super important.
And what's it called again?
Lipids or cholesterol check.
Triglycerides.
Right. And the most important thing aren't the numbers. And I often explain to patients when their results come back, a number is a number. So I take those numbers, and there's actually something called the Framingham risk calculator. It was made after several studies were done showing how risk affects heart disease. And I literally, in my electronic medical record, it involves the patient's age, their cholesterol, their most recent blood pressure, whether they're a smoker, and if they have any diabetes or any other risk factors. I click, and then it spits out a number saying, you have a 10% risk of developing heart disease in the next 10 years. So it'll give me a percentage that I can counsel the patient, like
50%
or
50.
90. So anything up to 10% is considered low risk. Diet, nutrition, lifestyle factors. Once you get into the moderate risk category and to the higher risk category, that's when we start talking about maybe adding something like a statin drug.
Medications to support.
Yeah, that's a crazy stat. 45% of women over 40 have high cholesterol.
Mm-hmm.
Yeah. I wonder if is that an American? We're always fighting. She does all her training in the American system.
Yeah, unfortunately. But
I mean, they're pretty
yeah.
matched.
Yeah.
But
The numbers might be a little bit
Yeah.
different because they have higher
Yeah.
population, but yeah, keep going.
Okay, central obesity, like we were talking about, that visceral fat distribution is going to increase insulin resistance. So what happens if we have more tissue? Our body is stimulated to make insulin from the pancreas every time we eat something to help break down the sugar and get the sugar from the bloodstream into the tissues that need it. If we have more tissue, then there's increased insulin resistance. So the insulin isn't working as well, and that puts us at risk of metabolic syndrome and diabetes. And then menopause, we've talked about sarcopenia or even just muscle mass decline and decreased bone density. The muscle mass decline can actually increase the diabetes risk as well. And again, back to basics. We're always saying the same thing, no matter what the topic is. Move your body. It helps. I can see it in my numbers that I'm always looking at with my pump. Moving your body affects your blood sugar. When you move your body's working more efficiently, and the insulin is doing what it needs to get it out of your bloodstream and into the tissues.
Yeah, our muscles are major consumers of sugar.
Yeah, for sure.
They need lots of energy.
Oh my God, this is the Debbie Downer one. Okay, cancer. 40.
Sorry, it is a Debbie Downer for the beginning. It's like,
Right.
I'm here to scare you.
Yeah, and then we're going to talk about all the good things, right, Angie? Right?
Exactly.
Is that coming?
Exactly.
Okay. 43% of
Motivating.
Canadian, yeah. 43% of Canadian women will be diagnosed with cancer, and that's of all types. Most common,
Skin. Is that
including
skin?
skin, I would say so.
I would think so, because that's a high
That's
number.
a high number. But they say yeah, I was looking at the Canadian statistics.
Yeah,
I think it's 2 in 5 Canadians will be diagnosed with cancer in their lifetime. So
42%.
yeah, so that is including skin cancer, even like a basal cell that doesn't have any risk of spreading. It's not just melanoma. There's local skin cancers which don't have a high risk, but the most common: breast, lung, colorectal, and uterine. That's why we have a breast screening program in our medical system. We now have a lung screening program for people who have had at least 20 pack years history of smoking. So it's a one-time low dose CT of the chest as a screening test if somebody is deemed at higher risk. Colorectal screening is every 2 to 3 years. A FIT test, which is a test that we order from Life Labs or Dynacare, I can't remember. It's sent to your home with instructions. You put it in the mail. It's supposed to be
a stool one.
Yeah, it's a stool one, but it's not like the old fecal occult blood test.
Yeah.
It's a newer, like, immunoassay fancy thing, but it's a really good screening test for colorectal cancer if you don't have an increased risk in your family. If you have high risk or genetic predisposition to colorectal cancer, we often say go straight to colonoscopy. But as a screening test, every 2 to 3 years, the FIT test is a wonderful screening test for colorectal cancer. We don't have any uterine cancer screening tests, but I will tell you, uterine cancer is one that shows symptoms pretty early on. And the most common symptom is postmenopausal bleeding. So you go through menopause is done, you're postmenopausal, and then 1 to 2 years after, you have this bleed all of a sudden. Well, if you come into my office, there's no beating around the bush. I'll do an endometrial biopsy right then and there, no messing around, just to check that lining of the uterus as a investigation for uterine cancer. So it's a really easy thing to do. Most practitioners in town will do an endometrial biopsy and not have to send to gynecology. It's kind of like getting an IUD in the procedure, but that's a really good test to if there's any suspicion for any uterine cancer.
What about premenopausal? Like if you're like perimenopausal,
Yeah.
is there? I know the
Ultrasound.
incidence is higher of uterine cancer after menopause.
That's right.
But before it, is it just any abnormal bleeding to get
No,
investigated?
abnormal. So 99%, and this is not quotable, please, but I would guess that in the 90% of women who are in the perimenopausal period who have abnormal bleeding, it's hormonal induced and not cancer induced.
Should still be
However,
if it's
there
new for you.
there's transvaginal ultrasound, which would commonly be ordered in this kind of circumstance if there is any suspicion in a woman who's postmenopausal, where they measure transvaginally the lining of the uterus. to make sure it's within the normal limits, because endometrial cancer is what most uterine cancers are, and it's a thickening of the lining. Sometimes it's hard to gauge when you're perimenopausal
Mhm.
because it can get thick and thin. It sheds like it always did since menarche or the beginning of menstruation. But it is one of the investigations that we can do premenopausally. Oh, look, regular exercise reduces breast cancer risk by 20 to 30%. And so does smoking cessation.
Yes.
Yeah.
If you are a smoker, it's the single best thing you can do for your health, and then exercise.
Quit smoking and get on the treadmill.
Yeah.
Mhm.
What was I going to say about I was going to say something about the uteri as well. I can't remember. Come and gone. There it is. I'll think of it in a bit.
Oh, this is the one for you.
Oh, sure, I can
Since
do
you
that one.
experienced it.
I know I did. I did. It was crazy. And I think it's one of the big things that impacts us in terms of our movement. I know it impacts my movement. I can't do the things I used to do, run as like I used to run. And when you're in pain all the time, when you're acutely aware of your knee every time you do a squat or something like that, or even go down the stairs. But it's 50% of women report chronic musculoskeletal pain in around this time of our lives. I tried to remove all the midlife.
Oh yeah,
there.
we hate the word midlife and it keeps popping up. We like get rid of it
I'm
and then it's
maybe
back
embracing
again.
it. I'm like,
Just embrace it.
I know.
Maybe
I know.
that's what we need
Yeah.
to do.
But it's super common. It's one of the most common symptoms, perimenopausal symptoms of women worldwide, actually. And we have estrogen receptors everywhere, so it impacts our joints. Again, the loss of estrogen impacts cartilage, ligaments, collagen, all those kinds of things. And while it may hurt to do it, the more we move our bodies, the better it is. And it should always, I hate to blame hormones for everything, so it should always be investigated. Because this is also often a time, like the time of hormonal transitions, is when a lot of autoimmune diseases can creep up and rear their ugly head. So rheumatoid arthritis, even diabetes, any like whatever, all the other, there's a whole bunch of funky ones out there, psoriatic arthritis, lupus. If it didn't show up, if you had any babies, sometimes it shows up during those transitions. But
Inflammatory bowel disease, there's so many
yeah,
autoimmune
oh gosh,
things.
it's crazy.
Yeah.
Yeah, but there's lots of different ones. So they should always be investigated before jumping down it must be my hormones.
That's the most important thing, right? If somebody comes in with new joint symptoms, it's never going to be just chalked up to, oh, it must be
shouldn't be.
hormonal. It's never, right? Never. That would never happen.
We're going to educate our doctors
Yes,
too.
yes,
I mean,
yes.
not in Huntsville because our doctors are fabulous.
Yes, absolutely. No bias. This is good.
No bias.
You want to talk about
I can
the
talk about
bones?
this. I've got a lot of the last ones, but I mean, you can talk about bones. You
I like-
probably more
Okay, yeah.
more know more of the like.
Osteoporosis, our screening for osteoporosis has really changed in the last 5 years. Typically, after the age of 65, it was recommended because women postmenopausally are at increased risk of bone loss to do at least one baseline bone mineral density. And then based on those results, educate. You just need more calcium in your diet and vitamin D supplementation versus lower bone mass or osteoporosis where weight-bearing exercises and even some medication like bisphosphonates to help rebuild bone. So 65 was let's do it one time and check. Right now, it's changed to something I'm learning about from the medical students that I'm working with. It's a FRAX score.
Yeah.
So what I'll tell you, osteoporosis.ca is my favorite website because it has great information for healthcare providers who are trying to keep up with the trends and the guidelines, and great for information for patients in terms of what to do to keep your bones strong and how to help when your bones are not as strong as they should be. And it has lots of great information on it. So this FRAX score is something you basically, just like the heart stuff, you risk stratify a patient based on history of fragility fracture personally, osteoporosis in the family, age since menopause, and then
have you been on drugs?
Have you been on medication like steroids?
Yeah.
That could
including
puffers.
Yeah, puffers, not just prednisone.
And that's not Ventolin puffer, but that would be something like Flovent or a steroid
Mhm.
puffer. So you come up with a score and then it says yes to screen or no, do a Frax in a couple of years. So that's really changed. I don't know how it's changing in terms of picking up osteoporosis, but in general, 20s, we reach our peak bone mass. After menopause, 6% of bone mass in the 3 years after your last menstrual period.
And some can lose 3 to 5 per year
After that.
in about 3 years' time. So we can lose a lot of bone mass over this period of our lives. And I think it's, again, our lovely, unfortunately, patriarchal medical upbringing. Women were just, oh, you're just a poor shrinking violet. Oh, it's just part of life for you to have a stress fracture in your back or to become frail or to get kyphosis.
Yeah.
Yeah, to walk hunched over. But it's not. There's things that we can be done to help prevent it. And I think we need to talk about it more because it increases or impacts
Does
health.
that bone mass loss, you said 6% in 3 years, so does that mean the next 3 years it's another 6%? And every 3 years?
I think once
thereafter?
things stabilize, like
Okay.
through that kind of those menopause, like when you're actually looking at when you are menopausal and there's that like rapid decline of estrogen,
And then it kind of levels
and
out
then
a
it
bit.
levels out, but then you just kind of normalize, like then you're at a normal risk factor, which might be 1% per year, I think is what it was, if I remember the numbers correctly. But again, weight bearing exercises,
Yeah.
including, your Pilates, yoga. I mean, anything that just basically just move your body.
Vitamin D, vitamin D, vitamin D.
Vitamin D.
That's been hammered into everybody's head. Yes, yes.
Not excess in
No,
excess though. We don't
not
need
10,000 units.
and it doesn't cure everything. It is a fat soluble vitamin. So, but
But
I think generally speaking, for those of us, especially those of us that live in northern climates,
Canadians in
and
the winter.
yeah, we wear a lot of sunscreen. We shouldn't
Yeah.
be, things like that. That I think 800 to 1,000 units
I'd say
is
1,000.
recommended.
Postmenopausally, 1,000 to 1,500 is what I recommend.
Yeah.
How often?
1,000 to 2,000.
I know.
How often?
How often?
Daily.
Oh, every day. But because it's a fat soluble vitamin, the secret is you can take, like, you could take 10,000 and it lasts for a week.
Oh,
Because
okay.
it's fat soluble, it doesn't
So you
have to
could
be
do a
taken every day.
10,000.
You can take a bigger dose for the week and it can still work as well.
But not 10,000 a day. That might be a
No,
bit
that's too
excessive.
much.
Yeah.
How much a day?
So
About
1,000
1,000,
is a
which I think
good,
is what they're generally sold
Yeah.
in.
Yeah.
That's the D3,
that's right.
right?
Yep.
But you can also get it. There's some you can get in your diet. I think like egg yolks and butter and a few things like that contain some vitamin D, but not a lot.
Sunshine that we don't
Sunshine when we can. And it doesn't
see.
take a lot of sunshine for those of us who can be out in
Yeah.
it. Like your hands and face for 5 minutes. You can absorb a lot of vitamin D that way as well. And with calcium, I think like if you lack calcium in your diet, whether it's restrictions, whatever that is, then you want to supplement it. Either you can get a full dose, you can get partial doses of calcium.
I have
Yeah.
something to say about calcium.
Sure.
So with calcium, what we're saying in our practices, we're supposed to be saying is trying to get calcium in the diet is number one, right? It's the best way to absorb calcium is through the diet. There are a few studies that had questionable, including the Women's Health Initiative that we often talk about.
Yeah.
Does calcium in a supplement increase your risk of heart disease? We don't really think so, but the jury is still out and there's further studies that need to be done to confirm that. So in the meantime, I've been recommending trying to get dietary calcium, at least 1,000 to 1,500 milligrams of calcium per day through the diet.
Maybe we can get Allie to talk about what that looks like in a meal.
Yes, nutrition is next month and we have a nutritionist coming to talk to us. So that's a great idea. Yeah.
Yeah, and I think
make
there was
note of
like
that.
if you overdo calcium, you may get kidney stones.
That's it.
I think is one of the things.
Yeah.
So again, there's always a fine balance when it comes to minerals and vitamins and things that we take. More isn't always better.
Yeah.
So
That's
despite
true.
what some people will try to say.
Yeah.
So if we get to the fun part, as far as I'm concerned anyway.
Oh yeah, this is your bag, baby. I'm looking up vitamin D here.
Yeah, that's okay. You look vitamin D. So physical activity really is the best medicine. If exercise were a drug, every practitioner would prescribe it and everyone would take it. Because it impacts basically every part of our mind, body, and soul. It really impacts everything. It reduces the risk of, and can also treat and reverse often, heart disease, type 2 diabetes, or like, pre-diabetes, cancer, osteoporosis, depression, and dementia. There's some great stats on exercise and dementia. It's free. It has no side effects. It works better than most medications, but it can be really hard to start and to do.
We could get Jane to do a whole session on this. She's a pro.
I know we should. And the minimum, so I will say the prescription and the minimum of what's recommended is the 150 minutes of moderate activity. But saying that, if you're somebody who's starting from zero, if you get 15 minutes of moderate activity to start, and you can slowly increase that by a couple minutes a week or a day or a month, that's better than the zero or whatever you started at. So the 150 is something to strive for if you're starting at zero, but give yourself some time and some grace to get there. That's per week. You can do it per day.
Oh my
if you want.
gosh.
Yeah, sorry, per week. And actually so if you are somebody that's getting that, then strive for 300. Try to double it. And for the the bone health effects, strength training, we just need 2 days a week. From a training perspective, I know that I don't recover like I used to when I do hard workouts. Now I can, like, it takes me many days. So it's also important to get those rest days in between, especially with strength training. So your body also needs to rest and recover. And of course, getting sleep, which we talk about. And all movement counts. What else did I put in my notes there? Yeah. So, but I'm often asked, what is the best exercise for menopausal women? Because it's a big buzzword right now, and it was like, oh, this is the best exercise, and that's the best exercise. Is it cardio? Is it HIIT workouts? Is it powerlifting? Is it Pilates? Is it yoga? The best exercise is just the one that you'll do. Like, honestly, at the end of the day,
It's so true.
just do something. And sometimes that motivates you then to do a little bit more, right? So you could get into, I think when you want to get into the nuances of what's the best exercise now, it's like, are you doing the basics to start? If we're not doing the basics, then the best exercise is the one that you're actually just going to stick to on a regular
That
basis.
you enjoy and you're motivated
Yeah,
to do.
exactly. Enjoy. You can do it consistently, even on your really, really low days. And I'll get to that in a bit as well. But we just want to prioritize this movement that is, it can be energizing if we're on a super high day and it's great, or we might want to do something that's a little more relaxing if we're ready to strangle those around us. Something that's fun, engaging. I think we've kind of gone away from like exercise classes, but I think those used to be amazing. And then you can bond, forge great friendships. So find a buddy or join a class, or I don't know, now that we're getting to be hopefully nicer weather and this mounds of snow goes away, we can get outside a bit more. We want stuff that'll build our capacity and our confidence. What if you're terrified of going to the gym, and and you have a bad experience, you'll never go back. So we want something that's gonna to get us there as well. And makes us feel good and gets us moving in as many different ways as possible. Dancing in your kitchen counts.
Are you still doing training stuff? Of course. Yes?
Like at the pool?
Yeah. Do you have anything to add?
Swimming is great.
She's a special expert.
And swimming, like I've noticed a lot more older-ish ladies participating in the class.
It's easier on your joints.
That's it.
Yeah.
You can still get a
It
great
is.
workout
Yeah.
in.
I hear these aquafit classes get booked up so quickly. People are lining up at like 5 a.m. or something crazy. I swear to you, a patient told me that. They're with the bikes.
These are oh yeah.
Oh, the one with the bikes.
The bikes,
Yes.
that's what I meant. Yeah. Those hydro bikes
Those people tend to be quite a bit older. I would say most of those people are probably in their 70s.
Yeah, those are the patients that have told me about it.
Yeah.
And they're the ones that get there early
This is it.
and do it. And God forbid if you try helping them or move their bike.
We got a little possessive.
Oh no. Don't touch my hydro bike.
Yeah. I've heard great things about it though. Somebody who's got really bad knees
Yeah.
Really,
it.
really enjoyed the hydro bikes. Yeah. So I mean,
And
just,
like post knee replacement, like after the
yes.
rehab is done, that's a really good.
Yeah, there's so
Even
many
just
great things.
getting a belt, there's lots of, the old ski belts.
Yeah.
Yes.
We have those, and a lot of people just go and run in the deep water.
Okay,
yeah,
so a
that's a
little
great
weighted
idea.
belt, so
No,
that
it's not weighted,
it's
it's just for buoyancy. Like half of us do not need
I
buoyancy,
see. Yeah, fair.
but
I sink like a rock.
yeah,
Need
it
buoyancy.
helps.
Yeah.
Oh, that's cool.
A lot of athletes, if they're injured runners,
Yeah.
they'll go and run in the pool.
Oh, that's
Because you have
great.
resistance lifting. and
Right.
Yes, that's
Huh.
great.
That's a great idea. Yeah, so many things out there. So just a little bit of a recap, the science of muscle and metabolism. So after 30, our muscle mass starts to decrease per year. So even elite athletes, as they age, lose muscle mass, even if they're continuing to try to build muscle. So you're kind of fighting against it if you're not doing it. Our muscle is our metabolic engine, like we talked about. Lots of glucose and lots of energy goes into muscle. The more muscle we have, the better insulin sensitivity we have, the faster our metabolism and our stronger bones. So this is why if we're looking, let's say we're pre-diabetic, or our cholesterol's kind of coming up, or we've got high blood pressure, things like that, just building more muscle. And if you're looking at losing weight, doesn't have to be just the subcutaneous stuff, which is the stuff we can pinch, but even if the goal is to lose that, then you'll still lose the visceral stuff as well. It'll come off as well. You can't spot train it. It won't, one won't go off. We like get rid of that visceral fat first. It doesn't work that way, but as we're, losing our subcutaneous fat, if that's a health goal for us, then our visceral fat will reduce as well.
And it just makes the machine work more efficiently with more muscle. It just things
Yeah.
work better.
Yeah, and sarcopenia is the term for muscle wasting, basically, and it causes a lot of problems. That's when we can't, it's hard to get up off of the couch. We can't get up when we've fallen because we just don't have the strength to get up. So,
And these are lack of estrogen effects, but also regular
Aging.
effects of aging.
yeah, so it happens to men as well.
Yeah.
They just generally start out with more muscle unless we've built it up before the age of 30 or 40. But I don't know if like online, there's this woman called Train with Joan. I think she's in her 80s or so, or 70s or 80s, and she started training, and the woman is ripped. And she
Does
just
she
was,
look like that woman? That's a great
well,
shot.
she's a lot older than
Yeah,
this one,
okay.
but yeah. I know, I think Maggie put those in there.
Okay.
So it was never too late to start. She started lifting weights because she had health issues, and wanted to get healthier and better. And she exercises everywhere she goes. She's got a massive platform. She trains other people now, and she's in her 80s. And I'm always inspired by that. So it's never too late to start. You're just finding the safe place to do these kinds of things. Exercise impacts our brain health. Women have at least twice the risk of Alzheimer's disease than men, and dementia. I think we're actually a 3-to-1 ratio. And exercise can reduce dementia risk by 30 to 50%, which is a massive number.
Crazy.
Yeah, and there's more and more research coming out on this now. So it's not just for our physical, like, what our body looks like, or heart health, but it really impacts our brain health as well. Our, brain derived neurotrophic factor is basically a protein, like a fertilizer for the brain. It helps grow brain cells and strengthens connections between the neurons and protects against cognitive decline. So it supports our memory and our mental sharpness. Yeah. So aerobic exercise and strength training, high intensity training, just being consistent, and moving beyond exercise. So there's something called NEAT, or non-exercise activity. It's all the things that you do when you're not doing intentional exercise. So laundry, gardening. Some people, we've kind of gotten away from talking on the phone, but I was always a pacer when I talked on the phone, or if you're sitting. My mom's a knitter, but when she knits, her feet are doing this. So all of that is a little bit of movement that you can add into your day. If I've got a long drive, I'll sit there, and that's my work stuff.
Oh, sorry.
Yeah,
I'm
that's
like,
okay.
somebody has a message.
No,
Somebody has a question.
if a long drive, especially because my butt starts to hurt, I'll just start squeezing my butt cheeks. I'll do my Kegels too, but because I'm just like, I'm sitting there for too long, so I'll start to like tense and relax some muscles. If we have office jobs, if we don't, my watch will remind me to get up every 50 minutes.
Standing desk.
I ignore it, but
Yeah, right. But
I'm too busy.
Yeah, standing desks
Yes.
can be helpful.
Yeah. So all those little things adds a little bit of movement into your day. And mental health. I mean, I think many of us know it's easy to get sucked into, I don't feel good. I don't want to get out of bed today. And if you need that, we need that. But I know for myself, when I've felt like that and actually pushed myself to get out and went for a walk in Limberlost or whatever I was like, I'm so glad I did that. Was it hard to get out? Was it after a couple of days of being in bed and not feeling like myself and feeling super low? Absolutely. But when I finally got out, I was like, okay, I need to do it. I got to remember this feeling because it just helped me feel so much better. And the studies have shown that it can be as effective as antidepressants for mild to moderate depression. Our severe depression is we need a lot more than just movement, but it can boost our mood, as many of us knows. It releases endorphins and lowers our cortisol, which can help us sleep better sometimes. Sometimes it keeps us up like this. I can't go late at night or I'm up all night. Gets me too wound. And it improves our sleep quality and just reduces anxiety and self-confidence. It literally impacts everything. So we know that estrogen alone doesn't help us lose weight, or menopause hormone therapy or HRT or whatever you want to call it, because the studies have shown that those without any other factors, HRT or menopause hormone therapy or just estrogen therapy doesn't cause us to lose weight. Now, if we're not sleeping, can those kinds of things, can that help? It can, but estrogen alone isn't going to do that. So we need to do our resistance training. We need to increase our muscle. And yeah, it's not just about our calories. Menopause changes how fat is stored and burned. So we're kind of working against what we've always known. So what's always worked probably isn't going to work anymore. So when we were a little bit younger, and yeah, the best weight management tool is resistance training. Yeah. Yeah, because we didn't
Yeah,
for
that's
the
what I
other
was
one.
hoping.
And I always kind of talk about this, the impossible ideal and body image. So maybe for some of us, I know my mom, like, well, I grew up in an environment where she would idolize Twiggy, so everybody was very thin. Twiggy was a model that was like a super thin model back in the 60s, I guess, and 70s. And so I grew up in that. And every time, like I still have food drama. Every time I eat something, I think, oh, I should probably do an extra little walk, or I just would like to not think about what I'm eating. I just want to eat it and enjoy it. And so exercising, I think a lot of us at some point in our lives may have these goals. We exercise because of how we want to look, but I think trying to shift the mindset to what our body can do for us, that we're reaching health goals, not unrealistic body expectations, and especially with social media now, we see all these people that probably have used filters and all kinds of things, and we're comparing ourselves to probably the wrong age group too. Um, and redefining strength and health, and beyond weight loss, basically, and also self-compassion. So like I can't do the things I used to do. I still want to play soccer. My mind says I can do it, but my knees are like, oh no, you don't. No, 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 no. Like it took me forever to recover after soccer this season. I'm like, I don't think I can play anymore, but it makes
But
me
you
sad.
did.
I did, but I don't know, maybe I'll go coach. Um, yeah, but having compassion for our body, doing what we can, right? And also trying to get to the root of some of the problems if we can, fix it where we can. So our personalized health prescription, again, exercise is the best preventative medicine. A strong woman, we live longer and we'll focus on strength and mobility and vitality, and making small sustainable changes lead to big health rewards. So again, if you're starting at 0, adding 2 minutes is much better. If you're starting at 30 minutes, adding 5 minutes, every little bit helps. I think we get a lot of all or nothing thinking, where it's just kind of like, oh, well, I missed last week. I got to start all over
If I
again.
didn't do my 150 minutes, I'm not going to do it.
I'm not going to do it at all. But every little bit
Which is
definitely
tempting
helps.
at this time of year,
Oh yeah,
right?
we're watching How I Met Your Mother. I don't know. That's quite the show, actually. I'm like, oh, this is like maybe we should be watching that.
Oh, there's worse.
Yeah, no, yeah. So, but I always, like I said, wanted you to walk away with some tips and tricks. So, I think at this phase, it's like in any phase of life, really, we want to plan and prepare. So, have a plan A and a plan B and a plan C. Do you need to go hard to be effective every time? Absolutely not. If it's a good day, a high energy day, and we're feeling like it, get out there and do the things that, go for the big run or the whatever it is that a big paddle. I don't know, whatever you're just like, yeah, I can do this today. I've got lots of energy. Maybe you have that planned for your Wednesday, but you're just kind of a little bit bagged. Well, you still do it, but just go for half the time or do half the amount if you're weight training or something like that. Or on your days you're totally zapped, completely frazzled and stressed, which for a lot of us is most days. Just a little bit
10
of maybe a bit
minutes.
of yoga, a bit of like a recovery workout, meaning just like something super light, a bike, a swim, a walk, rest, nap, take a bath, have a scream, whatever you need.
What I do is I get home and it's like still light finally now at this time of
Mhm.
year. Oh my gosh. And I'm like, okay, dog. The dog
Yeah.
must need a walk by now. So then dog comes and we go for our walk. With our evening session, which I missed, unfortunately, we had Ashley from Fit Gym come
Mhm.
early and do a strength training. I hope we can get her again because I don't think the turnout was ideal. And
Well, it
she
was a
said
snowstorm
it was a
too.
snowstorm.
Yeah.
But there's a lot of intimidation around that heavy weight training, me included. I was really excited to try that. So hopefully we can get her back because I just where to start is where I am
Yeah.
personally, like in terms of the strength training piece. Um,
Yeah.
anyway, I thought that was a really
Yeah.
cool
Yeah, it was
resource
it
to
was
have.
great.
Yeah.
Yeah. But even if like, you're not sure where to start, a super low day and you just want to watch TV or whatever it is, just I don't know, like flex your toes a little bit, stand up and do a few body squats, shadow box. If you're really mad at somebody or punch a pillow. That's what I like to do. Um, mobility, I put morbidity. Nope, not
Not
morbidity.
morbidity work. We're not working on morbidity.
Mobility.
We're working on
Some
health.
mobility.
Mobility work.
Or
That's
just
funny.
breathing. There's so much we can do. Foam rolling, stretching, but just give yourself some grace, grab an accountability buddy, which is
Yeah, those
super helpful. Well,
like
you
with
can
you
no,
can have
I mean a friend, like
like a IRL
an actual
in real
buddy,
life.
an IRL, yeah, and in real life, a person
That's
that you can be like, we're going for a walk. And like, I don't feel like it. Okay, but I'm coming over. We're just gonna go for a tea, and they sucker you into walking down the street anyway.
But for those of us who are competitive, it's also nice to have little challenges to
Yes.
get your
Yeah,
butt
when,
here, right?
know thyself,
Yeah.
right? If being competitive is what motivates you, if like Pat not doing his physio, I'm
Oh,
charging
yeah.
$50 a day because money is important to him. So I'm like, you're not doing your post-op physio.
Give me 50
Charging.
bucks.
I did say 1,000, but he said that was a little steep. So far, he owes me $50.
Only one day missed.
We just started it Monday. Yeah, because he wasn't doing it. I was trying all the tactics to motivate him.
Money.
You got to find what
Yeah.
motivates you, right? For some
Yeah.
people, it's money.
Yeah.
I'm like, oh, the money motivates me for every time I miss, something, I'm gonna put $5 in a jar, give $5 to my kids or something.
Yeah. Right.
Yeah. Yeah. So this isn't something you have to answer today, but just thinking about before you leave or at the end of the day, like what's your next step? What's one thing you will change today? And just what's one little thing that you can commit to? Even if it's just like I'm just gonna put my running shoes on, or put my yoga pants on or whatever it is. And then
Baby
I'm just
steps.
I have driven to the gym and sat outside of the gym and just sat there in my car and I sat there and I sat there. I sat there for like 5-10 minutes sometimes. I'm like, I should just go in. I'm like, "Eh." So I didn't. But I
You got
got
the
there.
shoes on and
I
you
got the
got
shoes
there.
on and I got there. I'm like, that's a step.
Yep.
The next time maybe like, oh God, just go in. Like, stop telling yourself you don't want to do it. So little things
I'm
like
like the
that.
one like that. I have to have a goal
Yeah.
Mhm.
and set out a plan
Yeah.
for like what the months it takes to
Yeah.
be there. Or the other thing, if I pay money,
Yes.
Then there's that accountability.
that's right,
Mhm.
because I have paid that money and I am not gonna lose that.
That's
So I'm
true. It's an
making it work.
it's a
Yeah.
financial investment,
Yeah.
and
I'm
sometimes
like,
that can be
yeah,
motivating.
and with team sports for me, because
Yeah,
the
yeah,
individual sports, I'm not super competitive against myself, but if a team is relying on
They
me,
need you.
Yeah.
right?
They
Even
need
if
you to
that
show up.
they
I
need
don't
me
want to play soccer, but
fine, my
but
team needs me.
we will forfeit if I'm not
That's the
there.
martyr.
Yeah,
That's the
for
martyr
sure.
in me.
For sure.
Yeah. Um, Partying early. Okay, sorry about that. Just checking that. I think that's
I love this.
There we go. Yeah.
Every woman should know how to clean.
So it's a powerlifting exercise, a clean.
I Googled
Pull
that
it up
at the
or
gym
clean
one
and
day,
jerk.
where to the clean and jerk,
Yeah.
and some porn site came up. Yeah.
Oh
Yeah,
no.
it's like, oh, no.
Oh my.
Wrong website.
So if
That's
you're going to Google clean and jerk, add like
Some
clean and jerk
exercise.
exercise.
Yeah.
The moral of today's session.
Yeah. Strength
Leave you with
training.
that.
Yep.
That's
I
funny though.
I heard a really good one that might be misinterpreted, and we're going to talk about this.
Or the snatch is the other one.
Oh,
The snatch.
snatch.
Pelvic floor physio. I guess there's this amazing app. Nancy Bozek got a consultant letter yesterday in the office, and we all worked together. And she's like, "Oh, guys, get a load of this. This doctor is prescribing buff muff,
Oh, no.
buff muff."
Yeah.
And we went on to the website at work, so I was scared, and it did not come up with porn, but it came up with, what is it? I forget what the motto was. It was something ridiculous, like every vagina needs a trainer or something like that.
Yeah.
Buff Muff. It's an app for pelvic floor physio,
Apparently it's
and
really
they don't
good.
pay me any money to advertise it. I've heard great things.
I've heard it's very good.
Buff Muff. I'm
Buff
going to
Muff.
check it out.
Yeah.
But we'll talk about that when Carolyn and Brittany
Yes.
are here
Well,
for
they'll
pelvic
talk about it.
pelvic
That's
floor.
their bag.
Yeah.
Yeah. Anyways, I think that's
Are we good?
yeah, I think that's about it.
Perfect.
I'm good for my lunch. Any questions while we're in the room? Any questions online?
What were
Based
the
on all
two
that.
vitamins? D and, oh, calcium.
Yeah, so calcium in diet and vitamin D. I was looking it up. I wasn't checking Facebook while you're talking. The evidence is more supportive for just daily, but if you're somebody that doesn't want to take daily, it's a good backup option, but maybe not as efficacious and potentially higher risk with the higher doses for the
Yeah.
hypercalcemia and kidney stones. So daily is optimal, but if you're somebody who is not going to take any except once a week, I
And
would
do we
say
have to take magnesium with calcium and vitamin D?
no, it can help.
That's the only thing I take. I take
Because
it at night.
magnesium.
Yeah.
Yeah, magnesium has
Some
so
people
many
find it helps
benefits.
for sleep.
And
but
sometimes I think the calcium and magnesium are often found together in supplements.
Yeah.
Because of the way it's absorbed, I believe.
they work together.
Yeah. Any other questions? I heard methylated
Methylated
folate.
folate can help. Can help with what, Sophie? Sorry.
I'm gonna look it up.
Yeah.
I don't know.
Methylated folate.
I don't know about methylated folate. Maybe we could ask Allie about that.
Yes, we can. Oh, absorbing vitamin D and calcium. Methylated
Okay.
folate to help absorb. We'll have to look that up, Sophie. That's a great question.
Calcium. That's great.
I do know,
don't know anything about it.
one of the things that I was listening to a podcast the other day from a doc in the UK actually, and talking about restless leg syndrome, and often what she says is get your ferritin checked. That often restless leg is low iron.
100%. That's the first
Yeah.
thing I think about.
Yeah, low iron. But even if you're on the lower end of normal, that they still recommend iron supplements if you have restless legs. What is our normal range for iron? Is it 30? Is the low end?
Ferritin is 30.
Ferritin, sorry, 30.
Yeah, 30 and above.
So
like
if you were
200.
like 32 or 35 and had restless legs, it might be worthwhile trying an iron supplement if your ferritin is low.
And
But
Sophie,
yeah.
I can't find anything quick on the methylated folate, but I'll get back to you.
Yeah. Let's go. Okay.
Thank you. Thanks for coming, you guys.
Guys.
We'll see you next month.
Thanks. Sorry I couldn't be there.
That's okay.
We get it. Was that Maggie, I'm guessing?
Yeah, I think that was Maggie.
No.